Welcome to this Step 2 clinical knowledge review on Ophthalmology Emergencies test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for eye emergencies and teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the ophthalmology and neurology sections of first aid and your question bank before or alongside this video. Here is what we are going to cover today. First, we will learn how to recognize high-yield question stems for ophthalmology emergencies. Second, we will apply specific strategies for questions about acute vision loss, the red eye differential, retinal detachment, and temporal arteritis. And third, we will master the next best step question format for diagnosing and managing ophthalmology emergencies. This video assumes you have some baseline knowledge from your review resources. We are here to sharpen your test-taking approach. Our first strategy is the red eye differential split. When you see a question about a red eye, immediately ask yourself, is this painful or painless? For painful red eye, the key questions are whether there is vision loss, photophobia, and what the pupil looks like. A painful red eye with decreased vision, halos around lights, and a mid-dilated fixed pupil is acute angle closure glaucoma until proven otherwise. A painful red eye with photophobia, ciliary flush, and a small irregular pupil is anterior uveitis. For painless red eye, you need to look at the discharge. Bilateral conjunctival injection with discharge and no vision changes points to conjunctivitis. The boards love testing these distinctions, so make this your first mental framework. Strategy 2 is all about building your acute vision loss framework, because the boards test this in many different ways. For sudden painless vision loss, central retinal artery occlusion gives you the pale retina with a cherry red spot. Central retinal vein occlusion gives you the blood and thunder appearance with diffuse hemorrhages. Retinal detachment presents with the classic triad of flashes, floaters, and a curtain or veil over the visual field. For sudden painful vision loss, acute angle closure glaucoma gives you severe pain, nausea, halos, and a fixed mid-dilated pupil. Optic neuritis presents with pain on eye movement and is linked to multiple sclerosis. Temporal arteritis causes vision loss with jaw claudication and scalp tenderness. These are board favorites. Now let us go through high-yield stem recognition. For acute angle closure glaucoma, the classic stem is an elderly patient with sudden severe eye pain, headache, nausea and vomiting, halos around lights, and a mid-dilated, non-reactive pupil. Remember, this is a true emergency requiring immediate pressure-lowering treatment. For retinal detachment, look for the classic triad of flashes, floaters, and a curtain or shadow spreading across the visual field. The next best step is always urgent ophthalmology referral. For temporal arteritis, the classic stem is a patient over 50 with new headache, jaw claudication, scalp tenderness, and elevated inflammatory markers. The key board rule is to start high-dose corticosteroids immediately before biopsy results come back to prevent irreversible vision loss. These stems repeat over and over on practice questions and on the real exam. Let us work through our first practice question. A 68-year-old woman presents to the emergency department with sudden onset of severe right eye pain, headache, nausea, and vomiting. She reports seeing halos around lights. On exam, the right eye is red with a hazy cornea and a mid-dilated pupil that is non-reactive to light. Intraocular pressure is markedly elevated. What is the most appropriate initial management? Take a moment to think about this before we walk through the answer on the next slide. Let us break this down step by step. Step 1, spot the pattern. Elderly patient, sudden severe eye pain, nausea, halos around lights, hazy cornea, mid-dilated fixed pupil, and elevated intraocular pressure. This combination is the classic presentation of acute angle closure glaucoma. The fixed mid-dilated pupil is the key exam finding that clinches the diagnosis. Step 2, apply the rule. The board rule is that acute angle closure glaucoma requires immediate multi-drug therapy to lower intraocular pressure. You need to use topical beta blockers like timolol, myotics like pilocarpine, and systemic agents together. Definitive treatment is laser iridotomy, but you must lower the pressure medically first. Step 3, eliminate wrong answers. Topical corticosteroids are for uveitis, not glaucoma, and can actually worsen intraocular pressure. Immediate surgical iridectomy is the definitive treatment, but medical therapy must come first. Oral acetazolamide only is helpful but insufficient as monotherapy. The correct answer is B, topical timolol and pilocarpine as part of multidrug initial management. Here is our second practice question. A 55-year-old man presents with a 2-day history of flashes of light and new floaters in his right eye. Today, he noticed a dark curtain spreading across his vision. He has a history of severe nearsightedness. Visual acuity is decreased. What is the most appropriate next step? Think through this one carefully. The key buzzwords here are flashes, floaters, and curtain. We will walk through the answer next. Let us work through this answer. First, read the question carefully. This describes classic retinal detachment. You have the triad of flashes, floaters, and a curtain or shadow spreading across the visual field. The patient also has severe nearsightedness, which is a major risk factor for retinal detachment. Observation and follow-up in 1 week would be dangerous because the detachment can progress to involve the macula, causing permanent central vision loss. Topical corticosteroid eye drops are for inflammatory conditions like uveitis, not for retinal detachment. Magnetic resonance imaging of the brain is not indicated because this is a retinal problem, not a neurologic one. Now, why does emergent ophthalmology referral win? Because retinal detachment is a true surgical emergency. Every hour of delay increases the risk of irreversible vision loss. The correct answer is C, emergent ophthalmology referral. Let us review temporal arteritis management for the boards, because this comes up constantly. The most critical board rule is this. When you suspect temporal arteritis, start high-dose systemic corticosteroids immediately. Do not wait for the biopsy. The reason is that vision loss from temporal arteritis can be permanent and can become bilateral if untreated. The erythrocyte sedimentation rate and C-reactive protein will be markedly elevated, but remember that a normal result does not completely rule out the diagnosis. For confirmatory workup, temporal artery biopsy is the gold standard. It must be performed within about 2 weeks of starting corticosteroids. The biopsy classically shows granulomatous inflammation with giant cells. Here is another important pearl. A negative biopsy does not exclude temporal arteritis because the inflammation can occur in patches known as skip lesions. The boards love testing the correct sequence, which is treat first with corticosteroids, then confirm with biopsy. Here is our third practice question. A 72-year-old woman presents with a 3-week history of new headache, scalp tenderness, and jaw pain when chewing. She now reports transient blurry vision in her left eye. Her erythrocyte sedimentation rate is significantly elevated. What is the most appropriate next step? This is a classic temporal arteritis question. Think about what the transient vision loss tells you about the urgency. We will walk through it next. Let us break down this answer. The classic pattern here is a patient over 50 with new headache, jaw claudication, scalp tenderness, transient vision loss, and an elevated erythrocyte sedimentation rate. This is classic temporal arteritis, and the transient vision loss tells you the eye is already at risk. This means you cannot afford to wait. Now the key distinction. Obtaining a biopsy before starting treatment would be wrong because the delay risks permanent bilateral blindness. Remember, the board rule is treat first, then biopsy. Ordering brain imaging is not the priority here because this is a vascular inflammatory condition, not a primary neurologic emergency. Prescribing non-steroidal anti-inflammatory drugs is completely inadequate for temporal arteritis and would not protect the vision. The correct answer is B, start high-dose systemic corticosteroids immediately. Here is a critical test-taking pearl. The red-eye quicksort algorithm. When you encounter a red-eye question on the exam, ask 3 questions in order. First, is there vision loss? If yes, this is an emergent condition. Second, is there pain? Pain with vision loss points you toward acute angle closure glaucoma or anterior uveitis. Third, what does the pupil look like? A fixed mid-dilated pupil means glaucoma. A small constricted irregular pupil means uveitis. This 3-question sort will work every single time. The exam loves to test your ability to quickly differentiate these conditions. Remember these key distinctions. Conjunctivitis never causes vision loss and typically presents bilaterally with discharge. Uveitis classically shows consensual photophobia, meaning shining a light in the unaffected eye causes pain in the affected eye. Acute angle closure glaucoma will have the hardest eye on palpation. If a question gives you bilateral red eyes with discharge and normal vision, it is almost always conjunctivitis. Commit these distinctions to memory because they are extremely high yield. That wraps up our review of Ophthalmology Emergencies test-taking strategies for Step 2 clinical knowledge. Remember to review the ophthalmology and neurology chapters in First Aid and your question bank. Focus on the red eye differential, acute vision loss algorithms, and emergency management protocols we covered today. Visit www.roadmap2residency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.